Please welcome Dr. Nadera Slice.
Thank you. What is the slideshow? Good morning. Thank you so much, Stephanie, and thanks for the organizers and the supporters of this conference. And I'm honored to be here every year since the year 2000, and I plan to continue doing this hopefully as long as I can. We will talk today about the advancements in scleroderma treatment over the last year, or over the last couple of years. As you know, in the field of scleroderma, it is hard to come up with a new medications that approved by the FDA every single year. It is hard to conduct clinical trials as many as we do in other diseases like rheumatoid arthritis. It is such a difficult disease to study, especially with the different presentations scleroderma have. This is my disclosure. I have nothing to disclose. However, I will discuss non-FDA approved therapies in the treatment of scleroderma. What is a scleroderma? It is a multi-system disease. The cause is unknown, but it's characterized by thickening of the skin that's caused by accumulation of connective tissue. And that thickening or hardening of the skin may affect the internal organs. It may cause hardening in the lung, in the heart, and in the blood vessels. The word scleroderma comes from the Greek, meaning hard skin. Early symptoms of the disease include cold hands, tightening of the skin, changes in the facial features, joint pain, heartburn, shortness of breath, and fatigue. We're grateful for the Scleroderma Foundation for spreading the awareness, because patient awareness is crucial in this disease. You need to be your own advocate and fight for what you feel is right for you as a patient. So being aware of your body and aware of what's going on in the field of science is important. Scleroderma affect many ages. The common age group is 35 to 64. However, it can affect children and it can affect people older than 64. Like many other autoimmune diseases, females are affected more than males. And the incidence is 20 per million per year in the United States. The prevalence, and that's a rough number, is 240 per million in the United States. I will go briefly over the classification of the scleroderma, just for the people who are here for the first time, before we go into the treatment. So the term scleroderma is used interchangeably with systemic sclerosis. The term we often use is systemic sclerosis. Systemic sclerosis can be limited or diffuse. And then we have the localized scleroderma. And then we have scleroderma mimics. Not every skin thickening is scleroderma. I will not talk today about the scleroderma mimics, but it's important when you are diagnosed with scleroderma to make sure that you do not have a disease that mimics the scleroderma. So when you hear the diagnosis of scleroderma, then you want to ask yourself, do I have the localized version or do I have the systemic version? So the localized version could be morphea or could be linear scleroderma. And we will not talk in details about morphea, but you will have localized area of skin thickening that can happen in children or in adults. And it tends not to affect internal organs. It's localized to the skin. Linear scleroderma, you see it mostly in children, where you may see one leg shorter than the other because of the tightening of the skin. Our focus in adults is usually systemic sclerosis, where this disease can be limited or can be diffuse, or one variant is what we call Scleroderma, where you may have the lung fibrosis or the pulmonary hypertension, but you don't have the skin features of scleroderma, and then that may occur later in life. But when patients present with shortness of breath and we find they have interstitial lung disease, we always ask the question, could that be scleroderma, Scleroderma, meaning silent scleroderma starting in the internal organs, then showing the features of systemic scleroderma. So the main focus today will be updates in the treatment on the diffuse type and the limited type. So the diffuse type, you can see in the picture there, the skin thickening involves the whole body. It does not differentiate. So it can involve the abdominal area, the anterior chest, legs, arms, and it involves areas proximal to the elbows and proximal to the knees. While the limited form, you see the white, where the white dress shows, this is where you do not see skin thickening in the limited form of the disease. So the limited form of the disease, again, the skin thickening is just distal to your elbows, mostly the hands, distal to your knees, and you may get calcium deposits in the fingers, a lot of red spots on the face, telangiectasias, as well as gastrointestinal issues mostly related to the esophagus. While the diffuse form, the skin thickening is all over, and Raynaud's occurs as well. Calcinosis is not very common in this form, and the lung involvement is can be serious in this form. So when we talk about the diffuse disease, we focus mostly on the lung and the skin, and when we talk about the limited disease, we focus mostly on pulmonary hypertension and Raynaud's, okay? So as a systemic disease, scleroderma can present with various manifestations. Raynaud's occur almost in everyone. And Raynaud's can be variable. It can affect one finger or all the fingers. The skin will be involved. The gastrointestinal tract will be involved. Dr. Brown will cover that. Cardiovascular, heart and blood vessels. Pulmonary, Dr. Streck will cover that. Renal, the kidney, and systemic manifestations, and musculoskeletal, meaning involvement of the muscles, myositis, and arthritis. What we mean by systemic: weight loss, the fatigue, poor sleep, associated depression, and anxiety. In addition to other inflammatory systemic features. So we don't want to neglect what happens if there is just the heart is involved. That's not it, because if there is pulmonary hypertension, patients with pulmonary hypertension have very poor quality of life. So medicine is changing, as now when we design clinical trials or look for new treatment, it's not only we want to fix the lung or fix the heart, we want to make sure the quality of life of patients is better. What's the point of fixing the lung by x-ray or look at the breathing test, it's getting better? Well, you cannot do what you want to do. What patients want mostly is they want to go back to where they were. They want to do the things that they're able to do before they got sick. They want to feel good. They hate waking up every single day, feeling tired, wishing for a good day. So I think incorporating measures of the quality of life is crucial in the treatment of scleroderma. I listed this in your handouts. I'm not going to talk about it, just as a reference for you about diagnostic criteria that are used in clinical trials. So when we make the diagnosis of systemic sclerosis or scleroderma, we depend on certain presentations or certain guidelines or certain features. but what we use for clinical trials may be different than what we use in day-to-day basis. So this is just for your own records. And again, I listed this for you to show the type of antibodies that we check for patients with scleroderma. Different hospitals may do different panels. Some hospitals may send the test out to Mayo Clinic. Other hospitals may do it locally. So there are different autoantibodies, but make sure to discuss these results with your physician. We will not go over the details of the antibodies or what they mean, but it is important not to look at the number and the antibody and see that it is abnormal and then you get so worried. Not every abnormal result means a disease. I can tell you from practicing medicine and seeing patients with scleroderma since the year 2000, I had patients who had a positive SCL70, for example. And this is an antibody that is well known to be a predictor of lung involvement. And those patients have been following them for 17 years. Nothing happened. They only have the positive antibody. So having a positive antibody without clinical signs and symptoms and without evidence of organ damage may not mean much. So we do not treat the antibody, we do not treat a blood test, we treat the patient. And let's take, for example, the skin. The skin, when it gets affected in scleroderma and gets thick, you see the skin score here in this graph. Is there a laser pointer? Oh, okay. I can maybe, oh yeah, here. So you see how the skin thickening may go increase with time and peak. And then there is a point whether we treat patients or we do not treat them, the skin score may go down and improve without treatment. And the skin score is the way we as physicians check the skin thickening when patients come in the clinic. So we try to touch the skin at the face, at the chest, at the arms, and we calculate a score. And the higher the score, the worse. So our goal is to treat the skin to make it softer. Now, if we do not treat the skin in the early phases, sometimes when the skin thickening improves on its own, there may be changes in the facial features. So patients will look at their pictures before they got scleroderma and after they got scleroderma, and there is a difference because of the changes in the laxity of the skin, the telangiectasias, the decrease in the size of the lip, the change in the mouth. So right now, although we don't have studies looking at treating very early disease, there may be a point of treating very early disease to try to prevent the disfiguring features that the scleroderma may cause in the face. Because especially for women, this is an important feature. And a lot of times, I focus mostly my research on women, and a lot of things that bother women in scleroderma, they don't like the red dots on their face. They don't like the way their face looks. They don't like the way how their lips got smaller. So now we are trying to look into ways to prevent the occurrence of these things, but if they are there, how can we treat them? How can we get rid of the telangiectasias or the red dots? How can we change the size of the lip? How can we improve the opening of the mouth? Let's talk a little bit about heart involvement and what's new in terms of heart involvement. It's very important whether you have scleroderma for 1 year or 10 years that you focus on your heart health. The common causes of death in a lot of autoimmune diseases is the heart. And we don't want to neglect coronary artery disease or blockage in the heart from high cholesterol and from lack of exercise or from genetic factors that may increase your risk of death from heart disease. So it's always important to see if you have high cholesterol, and sometimes a normal LDL may not mean much. We may need to do fractionation of that LDL to see is is because there is a good LDL and a bad LDL. We always think LDL is bad, but sometimes the size of the particle may indicate that the LDL, even if it's a little high, may not be that bad. And the same applies to HDL. That test is not available in many centers, and there is a debate whether to use it in everybody. So, but if you have a family history of heart disease, people dying at young age from heart disease, it's important to focus and see if you have a risk of getting heart disease early on, or what's your risk of developing myocardial infarction or heart attacks. Patients with scleroderma, whether it's systemic sclerosis, whether it's diffuse or limited, there may be increased risk of peripheral vascular disease, partly because of the disease itself, partly because of maybe high cholesterol, and partly because of the treatments we give, especially if we give prednisone for long term. So if you have not checked your cholesterol, make sure that your cholesterol is checked and you're following a regular exercise program, and that your heart, at least you have a stress test to make sure you're not at risk of heart attacks. Now, the scleroderma can affect the lining of the heart, can affect the cover of what we call the pericardium, can result in fluid around the heart, and it's important to get an echo or ultrasound of the heart once a year to make sure that you're not developing fluid around the heart. Because having fluid around the heart is not a good sign, and that's one of the things we need to keep an eye on. Let's talk about digital ischemia in patients with scleroderma. Here are some pictures that will show you the patterns of ischemia. Here you can see the ischemia is in one finger. So if you see your finger turning white and it doesn't go back to normal color within 10 to 15 minutes, this could be an emergency. You don't want to wait longer. So you look at the finger, if it's that color, or even if it's blue that color, what you need to do is rest. Thank you. You need to rest, wrap your fingers, and don't do much. You need to relax. So one of the very important things to do when you get an acute Raynaud's attack is to sit at home in an adjusted temperature and try to talk to your doctor, see if there is a need to be admitted to the hospital. Certainly, if this is going on for more than 20, 30 minutes, we admit patients to the hospital with this. So, because you don't want to wait until you get gangrene or digital ulcers, okay? So this is something you discuss with your treating physician. Ulcers, yes.
Is there a difference between the two, the one that is dusky and the other one?
Yes, the one that's dusky here, this could be one phase. So Raynaud's could be 3 phases or could be 1 phase. So you could start with this color, then go to the white, and there could be change in the colors, but one patient may get this color and the fingers are cold. So if you get this color and the fingers are cold, this is a bit different pathophysiology than when the fingers are white. So if we see this color alone, we start as physicians looking for other things, blockage in the neck, other diseases other than pure Raynaud's related to scleroderma. So you can see the 3 color changes, or you can see 1 color change in patients with Raynaud's. In terms of prognosis, is one better than the other? It varies. It varies on how long does it take to rewarm the finger, and if there is digital ulcers or no digital ulcers, if there is gangrene or no gangrene. Sure. Here's an example of digital ulcers, and you see the ulcers happen at the tip of the finger, but sometimes we can see ulcers that occur at the contracture sites, and we see often shortening of the fingers. And until today, over the last 20 years, we haven't made many discoveries how to prevent the fingers from getting shorter. So the 2 things I would say still we don't have much to offer other than treating ischemia is shortening of the digits. But even when we treat ischemia, we still have patients who still get shorter digits with time. So we try to measure the digits every visit, the length of the digit. And then the other thing is the calcium deposits, where we don't have many new treatments for that. So if we catch patients early when they have slight skin thickening, we can prevent these contractures. But once patients have contractures, it's hard to reverse them. So how do we decide on the treatment for patients with scleroderma? We try to follow published guidelines. We try to treat specific organs that are involved. We're striving to make early diagnosis and early referral to a specialist. And it's essential to treat what we can treat. Now, when we talk about published guidelines, I just want to say a few words about this. Guidelines change maybe every year, every 2 years, every 3 years. So guidelines are not set in stones. So if guidelines apply to one patient, they may not apply to another patient. You know your body best. It's important as a patient to define what do you want, what is important for you, and have an open dialogue with your physician to see which organs are involved and which organs need to be treated. And those organs that need to be treated, what treatment should be given? An example, you're diagnosed with scleroderma, you have Raynaud's, and you have difficulty swallowing and a lot of heartburn. Your lung is fine, your heart is fine, everything else is fine. Then you pick the best gastroenterologist that you enjoy working with, and you work with the gastroenterologist to fix the esophagus and to fix your heartburn. If everything else is good and your lung is affected, then you go to a great lung specialist who is familiar with, or she's familiar with immunosuppressive therapy, and you work with that person. If you have pulmonary hypertension, you go to a pulmonary hypertension clinic. If you have digital ulcers, you go to somebody who does research and have experience with treating digital ulcers. What if you have it all, and that's what makes it difficult for some patients? Then you try to pick a good primary care doctor that will organize your care, because it will be too much for you to go around and find what's new in every organ, and that your primary care doctor should work with the other doctors. And we're lucky because in a couple of months, we'll all have probably EPIC, a system, electronic medical records, in a lot of places in the United States. So basically, if you see me at the University of Illinois, or you go see another physician at Johns Hopkins, both will be able to look at the same records. And I think that's a great thing for patients. You'll be able to access all your test results. So keep track of the results of your echo, the result of your CT scan, the result of your breathing test. Let's start with updates on treatment now. I'll try to finish to leave some time for questions, so I'll talk for probably 10 minutes. Is there anything new in the treatments for the skin? So the safest and the commonest two medications that are used to treat the skin thickening, very low dose prednisone, low dose methotrexate, and mycophenolate or Cellcept, okay? I listed other medications there, but it depends on the risk and benefit. So if the skin thickening is the only feature and there is no internal organ involvement, then there is no need to go with aggressive medications. Then maybe low-dose methotrexate, if tolerated, and if you can't tolerate it by mouth, it can be given as an injection. That will be the way to go. I will not go over rituximab or stem cell transplantation or cyclophosphamide. For skin alone, I will not go into aggressive medications, okay? So skin alone, use simple medications that have a favorable side effect. Now, the Scott study, the famous Scleroderma study that looked at autologous stem cell transplantation in patients with scleroderma, found benefit in patients who had skin involvement. Does that justify we're going to send patients to have stem cell transplant only if they have skin involvement? The answer is no. At least that's my practice. So if it's only the skin, we don't go with aggressive therapy like stem cell transplant. So that study made it in our best journal in medicine called the New England Journal of Medicine. It took a long time to complete that study. And that study showed that potential benefit in stem cell transplant in a subset of patients with scleroderma. Now, how do we identify this subset and who would benefit most from stem cell transplant rather than taking cyclophosphamide? It's not very clear. Now, there are two forms of transplant because patients often ask me, if nothing else is going to work for me, how about stem cell transplant or stem cells? Two forms of transplant. One is called autologous stem cell, the one that was published by the Scleroderma group and the Scott investigators. And the autologous meaning they take your own cells, they treat them, and they put them back in your body, hoping that these cells will lose their memory to do the bad stuff, and then your scleroderma will be cured. And the other form of stem cell transplant is called allogenic, where they take the cells from a donor, and that donor is a matched donor, either a relative or a non-relative matched donor. And there is a debate which procedure is better. Right now, I think there is a program going on at Johns Hopkins using allogenic transplant rather than autologous. I am in the process of starting a program at the University of Illinois with our hematology oncology group for allogenic transplant. Since there are newer ways to do the transplant, it's less toxicity, cheaper. I want that option to be available for patients at more than one center in Chicago. I know University Northwestern does it, but I hope within the next year or two, we'll have a set protocol for stem cell transplant, allogenic stem cell transplant. We're going to try to use the same protocol used at Johns Hopkins. And you see here, I listed addition of anti-thymocyte globulin may eliminate graft versus host disease, which is a killer in bone marrow transplant. And there is something called PTCY, which is post-transplant cyclophosphamide. And as rheumatologists, we're experienced with cyclophosphamide. So the goal is you take cells from somebody else. Those cells hopefully don't have a bad memory. Then you put them in a patient with scleroderma. You hope those will be new cells. They will not, you won't have damage. And then you treat the body with high dose of cyclophosphamide. You hope that the disease will not recur for 2 to 3 years with being on a very small dose medication. Now, you may ask what's going to happen 5 years or 10 years. We don't know. That still need to be studied, and it's going to take probably 10 years before we have long-term data. Anything new in pulmonary hypertension? I listed for you the medications that are used in treatment of pulmonary hypertension. Now, I will not go over the details. That needs one lecture for pulmonary hypertension. Bottom line, there are 2 or 3 newer medications. No need to complicate the description of how they work and who are the patients who would benefit from them. But not every new medicine means it's better than the older medicine. If you have pulmonary hypertension, don't go for any surgery without getting clearance from your pulmonary hypertension doctor. You have a list of the newer medications. So your question will be, what is the best medicine that will work for me? Is oral therapy better than IV? Do I need a pump or do I need combination therapy? And that is something is dependent on your functional status, comorbidities, presence of diabetes, high blood pressure, and other medications. But there are 2 to 3 new medications that are used in general in the pulmonary hypertension world, and that could be utilized in patients with scleroderma. I will not talk about lung disease. Dr. Streck will talk about it. But in terms of interstitial lung disease, we still use mycophenolate mofetil, Cellcept, and cyclophosphamide. I got a lot of questions from patients about the use of antifibrotic agents, pirfenidone that's been used in interstitial pulmonary fibrosis. This is a very expensive drug. a lot of side effects, especially GI side effects. A lot of patients don't tolerate it, and we don't know the long-term safety in patients with scleroderma. So still the standard, even with the presence of new medications, the new agents are ongoing in clinical trials. We still stick to cyclophosphamide and mycophenolate as the standard. Now, there are thoughts about a medication we use in rheumatoid arthritis called Orencia or abatacept. And there are thoughts that it could be beneficial in some patients with interstitial lung disease. If you are interested in a clinical trial, look into clinicaltrials.gov and just search if you're interested in Raynaud's trial. It will tell you which are the trials that are close to you by miles, whether it's interstitial lung disease and scleroderma, pulmonary hypertension, or Raynaud's. So you can find new clinical trials, but here I'm talking about the standard. Is there something new approved by the FDA in the last year? The answer is no.
What was that website again?
clinicaltrials.gov. clinicaltrials.gov. You're welcome. What's new in the treatment of Raynaud's and digital ulcers? Avoid cold, avoid cold, avoid cold remains the most important discovery in treatment of Raynaud's. And it's not only avoiding cold, it's trying to keep the temperature around your hands always consistent. So then don't put your hand in the freezer without having your mittens or gloves on. And women ask me, how can I cook? How can I do things? Like, you can put mittens or gloves, then you can put plastic gloves on top of them, I know, but they have to be loose. You don't want things that are tight. But especially with weather changes, don't go out from a place where there is an air conditioner or heat to another temperature without having consistent temperature around your hands. That will trigger Raynaud's. Emotional stress, emotional stress, emotional stress does trigger Raynaud's in healthy people and more so in scleroderma patients. Try to avoid stress as much as you can. And if it's hard to avoid stress, just try to work with techniques that will help you deal with stress to minimize its effects on Raynaud's. Now, calcium channel blockers remain the first line treatment, but some patients may get headache, or get leg swelling. Try to see what's the best calcium channel blocker for you. But even with these medications, the response rate is 35%. So we try to combine them with something else. There was a lot of talk 10 years ago and 5 years ago about what we call ACE inhibitors, angiotensin converting enzyme inhibitors, or ARBs, angiotensin receptor blockers. There is no added benefit when you use it to treat Raynaud's, but if you have high blood pressure and it's needed for your heart, go ahead and take it. And it can be combined with calcium channel blockers. How about nitroglycerin? 2%. Dr. Wigley at Hopkins, I happened to listen to one of his lectures recently. He still recommends nitroglycerin 2% to apply, but you can't combine nitroglycerin with sildenafil or Viagra. You can't combine it with those phosphodiesterase inhibitors, and you may still get headache with it or low blood pressure. So be careful if you use it. How about Prozac or fluoxetine, which is a selective serotonin receptor uptake inhibitor, meaning antidepressants? I'm big on using these medications at low dosages in patients who cannot use calcium channel blockers. But there's only one study about it, and that study has not been validated. Phosphodiesterase inhibitors, including sildenafil and sildenafil, which is Viagra and Cialis. Those two are very commonly used now, especially sildenafil in patients with Raynaud's, in combination with calcium channel blockers. Oral treprostinil, and those are prostaglandin medications that we use to treat pulmonary hypertension. So the oral agents did not work very well for Raynaud's. There are other agents like iloprost and piraprost. All these are used for pulmonary hypertension. That's why I didn't want to confuse you with the names. But these medications do not work for chronic Raynaud's, but if you have like a Raynaud storm and digital ischemia, we admit to the hospital and we give these medications through the IV. Biofeedback, relaxation training, conditioning, acupuncture, laser therapy, and some herbal supplements that I listed, because I often get questions about those, including essential fatty acids, ginkgo, and L-arginine. We don't know the long-term safety, but at least we know that there is no evidence to support or refute claims of the efficacy of behavioral changes. So I would recommend behavioral changes, especially if you're somebody who cannot handle stress very well. It will be helpful. Now, I may add something here that's completely off-label. I did not publish the data yet, which is the use of medical marijuana. Well, I'm probably a high prescriber for medical marijuana for a lot of patients that I treat with sarcoidosis, a small fiber neuropathy. And I used it in a patient with scleroderma by chance, who had a severe digital ischemia. How are we doing with time? I have only one more slide. Okay. So I'll show you the picture. Let's skip this one. This is the patient that I gave medical marijuana to. So this man had issues with his insurance. I presented his case last year, and we could not do any surgery. At the time, Dr. Zachary was doing the Botox injection and fat transfer. We could not do it because of insurance reasons. And this is between here and here. It took me probably 3 to 4 years to get to that point. So what I want to say, this is a disease that don't expect miracles within a month or two. So it requires seeing patients sometimes every 6 to 8 weeks, change medications around. And how did we treat this case? Is trying to improve blood flow, try to suppress the immune system gently, try to target all the pathways that we think are involved in scleroderma. Of course, this is all off-label. So in this patient, I did put him on sildenafil, Viagra, plus calcium channel blockers, plus low-dose mycophenolate, plus low-dose aspirin, and many others, to try to improve the blood flow, because there is no way these ulcers would heal. But what was most important, he was working out in the cold weather. I had him apply for disability and not to work, because we wanted the hands to heal. But he continues to have severe pain. And there's something we're neglecting. We're finding an entity called small fiber neuropathy that we see a lot in diseases like scleroderma and Sjogren's syndrome. But I'm seeing more and more patients who have this body pain that nobody can figure out what it is, numbness, tingling, brain fog. We don't know if we're missing small fiber neuropathy in scleroderma, but guess what? If we want to prove it, we have to biopsy the skin in the leg, and I'm reluctant to biopsy the skin in the leg because I may induce an ulcer. So for this particular patient, I gave him medical marijuana. So medical marijuana in Illinois is legal, but you have to have certain diagnoses. Rheumatoid arthritis, you have to have either fibromyalgia, seizure disorder, severe Sjogren's syndrome. So I found myself prescribing more and more with it. So even patients, their reflux symptoms got better, they're sleeping better, they're relaxed more, and then but the drug is not regulated. So meaning you can go to the dispensary, get a piece of chocolate, or get a pill, or get a topical cream. In this particular patient, I had him get the topical cream, apply it to his hands. When he applied it to his hand and take a piece of chocolate before he goes to bed, Raynaud resolved completely. But this is something I haven't seen in 20 years. And now, again, could be a placebo effect. As a researcher, I have to prove it. We have to study it. But I started giving more medical marijuana to scleroderma patients where I see more response in the hands. Still, we need to discuss it with the scleroderma community and see how to proceed with this. How about fat transfer and Botox? We missed Dr. Zachary. Dr. Zachary and Dr. Elman were the greatest teachers in scleroderma and the greatest people who served scleroderma patients in Chicago community. And some leaders in the field of scleroderma don't believe in those two entities. A new randomized control trial done in Botox injection showed mixed results. So Botox doesn't seem to be working in everyone. But my advice to you, if Dr. Zachary say it may work for you, follow what Dr. Zachary say, not what the guidelines say. And the fat transfer, I've heard that there is a study that showed negative effects. But I follow a lot of patients who had it, and after 1 year of using it, maybe it works for a year, but then the symptoms come back. But you know what? If you live a good quality of life for a year, so what? Then we can do it later until we have something else, okay? So what to avoid? I listed for you for your handouts the things to avoid. Do not take diet pills, even if you feel you're a little overweight. Maybe a little bit being overweight is better than being underweight. So don't take diet pills because they will worsen Raynaud's. And we talked about this, that if you have severe digital ischemia, we'll admit you to the hospital. And what's the standard is to give the IV prostanoid. And sildenafil in combination. So we consider this as a medical emergency. A finger turning black, cold, color is not coming back in half an hour, and you start getting an ulcer, speak with your doctor. So what are the main advances in summary in the last 10 years? Which is the use of bosentan to prevent the occurrence of new digital ulcers. And bosentan, I participated in that clinical trial years ago. So there is nothing since that clinical trial was published. But that study showed that we can prevent new ulcers. But bosentan may not work with everyone. And I had patients, their liver enzymes went up. I had to stop it. So be careful when you use bosentan to follow the blood work carefully. And the increased use of Viagra and Cialis, and perhaps the use of bone marrow transplantation. I wish I had more new advances in the field, but I tried to be scientifically ethical, just summarizing what we have. But there is a lot to do, and there is hope. In conclusion, scleroderma is a multi-system disease. Individualized therapy is warranted. Outcome measures need to be defined in such systemic complex disease. We do need people to work together toward making the quality of life of patients better. And I believe scleroderma is treatable, and I still believe the future is bright. I think in the next 5 years, we'll have great strides in the treatments and research of scleroderma. Thank you for listening.